Middle-aged female with a 44-pack-year history of smoking presents with 4 weeks of hoarseness and occasional intermittent obstructed breathing. On flexible endoscopic exam, she is known to have a large pedunculated mass emanating from the left vocal cord which fills the entire glottic opening. The mass, as seen by the otolaryngologist, completely obstructs the glottic opening and moves in and out of the glottis with respiration. Unfortunately, that dramatic video is not available here. The patient was brought to the operating room and standard monitors were applied. The skin over the cricothyroid membrane was injected with local anesthetic with epinephrine, and the landmarks of the larynx and trachea were marked. A 14-gauge VBM transtracheal catheter fitted with a lidocaine-filled 10 cc syringe was inserted through the cricothyroid membrane and into the larynx. Aspiration of air confirmed the intralaryngeal position of the catheter. Following pre-oxygenation, the patient underwent an IV induction of anesthesia and maintenance with TIVA. A single-use Ventrain EVA ventilation device was attached to the trans-cricothyroid membrane catheter. Using a pressure-compensated flow meter set at 15 liters per minute, the patient was ventilated with an I/E ratio of 1:1 with approximately 1 second inspiratory and expiratory times. After each 5 cycles of inspiration and expiration, an equilibration pause was taken. Suspension laryngoscopy was applied and a telescope used to examine the larynx. The trans-cricothyroid membrane catheter can be seen beyond the mass. A cold knife technique was used to remove the mass. During maintenance EVA ventilation, the end tidal CO2 was not measured and the oxygen saturation never fell below 98%. During periods of intrinsic and iatrogenic complete obstruction of the airway, chest excursion could be observed. Post-excision telescopic inspection of the larynx revealed some kinking of the trans-cricothyroid membrane catheter, but airflow could be seen from the distal orifice as well as the mid-shaft manufactured perforations of the catheter. At the completion of the procedure, TIVA was discontinued and the patient allowed to emerge. When full consciousness and spontaneous ventilation was recovered, the trans-cricothyroid membrane catheter was removed. The patient was discharged home after 1.5 hours in the recovery room. She was instructed to remove the Band-Aid from her cricothyroid membrane puncture site the following morning.